Dr. Yurth, Dr. Elizabeth Yurth, I have been so excited and waiting to have you on the show. I can't believe we're almost 500 episodes in and we haven't chatted yet because we run in the same circles, but I
Yeah.
can't even tell you how excited I am for this conversation. So right off the bat, I need to thank you for your time and just share my excitement with you and the listener.
Amy, you and I have kind of circled around each other for a lot of years. So it's really wonderful to actually connect, at least by Zoom through this purpose. This is great. So thank
Exactly.
you. I really appreciate you inviting me here.
Oh my goodness, my pleasure. And we're going to have such a great conversation. So I'm encouraging all the listeners right now to just keep listening and literally take notes because you're going to need to take notes because of the things that we're going to talk about today. You're going to be like, wait, what? And you're going to rewind. And I know this because I have listened to Elizabeth be interviewed on many of my colleagues' podcasts, and I was taking notes. I was like, wait, what did she say again? Rewind. I wish I had a notebook. So definitely take notes. This is going to be just a one of a kind breakthrough discussion. So, Dr. Yurth, I want to start by talking about this whole concept of repurposed drugs. And I'm going to tee you up here really quick. So,
Okay.
in my community, whether it's my patients, whether it's just my listeners, I hear so often pushback on even taking thyroid hormone or
Right.
or bioidentical hormone replacement. And those are just hormones. So that's where I sit back and I go, listen, ladies, you have to think about replacing your thyroid hormone or replacing your testosterone, your estrogen, your progesterone. You are replacing hormones that are no longer being properly made by your body.
Exactly.
So, what's wrong with that? You can't think of it as a drug, as a medication. You have to think about it as something that's coming in that's going to give you life. So, right off the bat, I know when I say repurposed drugs, people are going to listen to it. They're going to be like, I don't want to take a pharmaceutical. I don't want to have something, that little orange pill container on my dresser. And they have such a resistance to medication. And listen, I mean, I get it rightly so because so many doctors out there are prescribing band-aid medications that people don't need. So many of them are being prescribed medications that have huge laundry lists of side effects that you need another drug for the side effects. But that's not what we're talking about here. So based on that, I want you to unpack this concept of repurposed drugs before we actually get into what we can be using for thyroid, for perimenopause, menopause, weight loss, all of that.
Wow, you are so right. Because as soon as people hear like the term pharmaceuticals or drugs, like, no, 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 I'm not taking any pharmaceuticals. And that closed-minded approach, unfortunately, maybe not at the best interest of your longevity or your overall health, right? I think that, you know, we get this all the time, right? Even like with you with thyroid. Okay, well, I want natural thyroid. Well, sometimes the synthetics work better than the natural, right?
Yep.
Sometimes those are just the more appropriate course. So, and most, if you look at even a lot of the drugs, the pharmaceuticals like aspirin, they are natural compounds too. So a lot of things come from natural compounds. Now, not all, and a lot of pharmaceuticals I'm going to talk about today from repurposing are not, but I think that we have to not sort of close our mind to things. You always have to look at anything, be it a natural substance, a supplement, or a pharmaceutical drug, as there is pros and cons to everything, right? And it's the risk versus benefits that we always have to look at and the appropriate use. I know a lot of pharmaceuticals that are dangerous, and I know a lot of supplements. When you look at all the pharmaceuticals out there, there is hundreds of thousands of FDA approved drugs. For a new drug to get to market, like if I decide I want to bring a new drug to market, it takes about 17 years. It is and about $3 million plus to ever get it there. So it's very, very difficult to ever get a new drug to market. So let's say I've done all this research and I figured out I really want this drug. I think it's going to be the best thing. If I want to bring it from a not available yet drug through the FDA to available drug for my purpose, it's going to take me 18 years and a whole lot of money. And in that meantime, there's a lot of lives lost potentially. So for instance, let's look at insulin. Insulin took 18 years. Once they figured out it was safe and effective for treating diabetes, it took 18 years to get to market. So if we can find drugs that are already approved and out there and utilize them in a different way, so repurpose them, then we can actually bring something to somebody much earlier, right? And so these are drugs that have been shown safe and effective for a certain disease. All right. And that's what we're going to talk about. So they were approved for a certain disease. But if I know the mechanism of the drug and I know what's going on with the disease I want to treat, can I find a drug that treats that? And indeed, there's tons. So let's start with something really easy. You guys all know about Cialis or Viagra.
Yeah.
These are called phosphodiesterase 5 inhibitors. We think about them for erectile dysfunction, right?
Right.
And they're great drugs for erectile dysfunction. But I will tell you, almost all of my patients, women and men, are on a low dose of Tadalafil. So that's the generic Cialis. So, and why? Because what they found is that men who took these drugs on a regular basis had much lower incidence of a lot of diseases, including dementias, including vascular diseases. So they actually found, wow, there's some other things. So they started looking at the phosphodiesterase 5 inhibitors, do all these other things that they might do. And not only do they actually improve, the reason they improve our function to the penis is because they're dilating blood vessels. They're improving blood vessel flow. Well, where is that going to be important besides my penis? How about my brain? How about my fingertips? How about my toes? How about my muscles? So you can use these phosphodiesterase inhibitors to improve the health of our blood vessels. And then there's a lot of evidence now, research showing their improvement in mitochondrial function. Oh. So if we think about one of the things that happens as we age, that's very detrimental to our ability to form muscle and to have good brains, it's mitochondria. So we lose mitochondria as we age. So you can actually use low dose Tadalafil. We're talking about 5 milligrams. So you're not walking around, with erections, but 5 milligrams a day to improve vascular health, to improve mitochondrial function, to improve inflammatory markers. So they also found that these guys had less arthritic pain because their inflammatory markers went down. They also improved thyroid from blood flow. So even when you have guys who like you can't get thyroid function optimized, sometimes the low dose Tadalafil will actually improve the vascular flow to the thyroid. So now your thyroid hormone is getting there more appropriately and doing its job. So, there's the neuroprotective effects, the vascular protective effects, the mitochondrial protective effects are going to help me in brain. They're going to help me in muscle maintenance. So they're banned drugs in the WADA, right? So they are, I can't put somebody who is a tested athlete on these drugs because they so do improve function. So that's a really easy one. It's cheap. It's well established. It has a great safety profile, and I can utilize it at a low dose, just a tiny dose for men and women.
For women too, though, that is
it's great, right? Don't we want better brains and better mitochondrial function and more muscles and better exercise performance? Of course. So it's going to do all those things for us too. So so the women are always like, tell their doctor I'm on 5 milligrams of Tadalafil. They're like, what? But so you have to educate people as to why they're taking it. Otherwise, they go back and they're like, the pharmacist said, why am I on this drug?
Sure.
But I love this drug, and I will tell you, at least 70% of my patients are on a low dose of Tadalafil.
Now, does it help to improve anything in the sexual department for women?
So it can probably have to dose it up a little higher, but you will increase orgasm quality and ability to attain orgasm a little bit because you're going to increase blood flow to the clitoris, just like you do the penis, right?
Right.
So taken before sex at a higher dose, it has been shown to improve orgasmic quality in women as well. So, but usually that 5 milligram a day dose, probably less so. You probably have to use it then like men do a little bit at a little bit higher dose, maybe 10, 15 milligrams to get some of that improvement. But and every now and then I do have a woman who actually just from the 5 milligram dosing will say they're having an easier time reaching orgasm.
Yeah. I mean, any little bit helps, right? Especially in midlife and in perimenopause.
Right, exactly.
Menopause.
Yeah.
So now I should have asked this question right off the bat, but I'm going to throw it in here so I don't forget because I know this is popping into the minds of the listener. Do you, with any of these repurposed drugs, let's say they're piquing the interest of the listener, do they go to their doctor and say, hey, doc, will you write me a script for a low dose of Cialis basically as a woman? And they're going to get looked at like they have 5 heads.
Yeah, you
Or
probably
are
are.
there other ways to obtain and utilize
I mean,
these?
these are prescription drugs. That is one
Yeah.
of the hard things about these repurposed pharmaceuticals. They are prescription drugs,
Yeah.
right?
Yeah.
So it's where you need a good, you and I would argue everybody needs a good functional medicine doctor. They need somebody who understands this stuff and a doctor who you can talk to. I mean, even your functional medicine doctor may not know about this, but if my patients bring me something that I don't know about, I'm like eager to learn. I'm like, okay,
Yep.
let me look into that, right? So you should have a doctor who, when you bring something to them, is if they don't know about it, they're like, oh, great. Thank you for bringing that to my attention. Let me look it up. Let me study it. Right.
Yeah, absolutely.
They
A
might not want
hundred
to give
percent.
it to you right away. I may want to go investigate it. But then once I investigate it, I don't think there's any downside. And I think that people will go, oh, okay, fine. I'm going to do that. So I think that when you're looking for a relationship with a physician, one of the main things you need to find is somebody who is your, kind of your cohort in this, not somebody who's just bossing you around, but somebody who's working together with you so you can teach them and they can teach you. So I think that that's one of the keys is finding a practitioner who can work like that, right?
Right. Right. And maybe if they aren't open to new information that you're bringing them, that's kind of a red flag for you right
Yeah, yeah.
there. It's
That's to
like,
my mind when a doctor says stop Googling something. I'm like, no, you should be Googling. You should be learning, right?
yes.
Don't go to Dr. Google. Well, actually go to Dr. Google and then bring it to me so we can talk about it, right? And I may say I may defend why it was wrong, or I may say, I learned something. So I
Yeah.
think you really, you've got to find somebody who you can talk to who's okay with you learning. You look at all the people you bring on your podcast and people hear that stuff and they want to go talk to about something. You need somebody who can talk about it with. So you've got to find those practitioners. And they do exist. They're a little harder to find, but they do exist.
They absolutely do. Okay, well, that's fascinating right off the bat about Cialis, microdosing that basically. What's next? I have a couple that I want to specifically ask you
Okay.
about, but I want to just kind of let you go. So I'll just let you go right to the next one that you want to talk about.
So I'll say probably one that's gotten the most press is Metformin. And I'm not a Metformin fan, and I'll explain why. So Metformin is a longevity drug. And the reason is, so we have these two competing systems in our body. One is called mTOR, mammalian target rapamycin. One's called AMPK. And AMPK is really for longevity. We want AMPK up and we want mTOR down. But you don't always want that because you and I are both into muscle building and you always want mTOR up to build muscle. So you've got to cycle these back and forth. You've got to have AMPK high in the long run, but not suppress mTOR all the time. You want mTOR to come up and then come down and come up and come down so I can keep muscle mass on, because in my mind, muscle mass is very critical to longevity. Mm-hmm. So what metformin does is it really activates AMPK pathway and it turns off mTOR, right? So why is that good? Well, because if I always have to gain AMPK, it's going to be like, I always think about AMPK as the endurance runner. I can go long term, right? I may not have tons of muscle, but I can go for a long time. That's what AMPK does. So basically, if I turn off mTOR, I probably will live longer. So it has been shown that metformin does reduce all-cause mortality. I use it a lot in cancer patients because in cancer, the last thing I want is growth. I don't want things that stimulate growth, right? So I will use it a lot in my cancer patients. It has some significant benefits on the gut microbiome. So it's really useful for helping people improve gut microbiome who have a lot of problems with gut issues. It can be really helpful for that group too. And obviously it controls insulin. So it really is good for keeping glucose under control and insulin modulated. But the downside, and why I don't use this drug a whole lot in my patients, is that inhibition of mTOR, because I am very big into resistance training and having my patients build muscle. Yeah. And if I'm giving them something all the time that's shutting down that ability, and these studies have been corroborated showing that as we age, if we are using metformin, it is much harder to build muscle. Now, again, risks may outweigh the benefits in some. So if I have a cancer patient, I'm less concerned about them building muscle. I want to keep them alive. So it's a great drug for those people, right? Or maybe my patient who doesn't really care at all about muscle, right? But in general, I try to encourage my patients to resistance train and build muscle. And so I don't use this drug a lot for that reason, even though it's very popular in the longevity world. And I'll tell you what I've replaced it with primarily are using our GLP-1 agonists. Mm-hmm. Right? The Ozempics,
microdosing, right?
And microdosing the GLP-1s, exactly.
Yeah.
And there's no magic. I see these people online advertising that take a big course in microdosing. There's no magic to microdosing GLP-1 agonists. You just use a small dose that maintains your weight. So you're not wanting to eat and you can maintain weight and you find that dose. It doesn't take a whole lot of these to get the longevity benefits, but the longevity benefits of the GLP-1 agonists are huge. That's why I get very upset with the press going after these drugs in terms of these are causing all these problems, right? Muscle loss and all these gut problems, and people are dying, and an Ozempic face. These are actually very valuable drugs. And the bad things occur when they're used inappropriately. So yes, if you don't eat, you will lose muscle mass. So if I have somebody on a GLP-1 agonist who I'm trying to get to lose weight, I'm going to make sure they're eating adequate protein, and I'll stop the drug if they're not, right? Mm-hmm. So yes, you have to eat, you have to maintain muscle mass. The GI effects are largely eliminated if you use these drugs appropriately instead of dosing them too high, maximizing the dose at too fast, and you don't get the side effects. So the press really went hard on these. They do not cause muscle mass. And there's a lot of doctors who are confused on this. In fact, when these drugs both first came out years ago for diabetes, they actually were shown to push glucose into the muscle and help the diabetic patients to gain back muscle because they weren't dosing them at weight loss doses, right?
Yeah.
So these are great drugs. Now, why are they so good for longevity? Because when you look at their improvements, not just in metabolic health, right? Because even at a low dose, that you're not going to lose weight, we do see significant improvement in metabolic health. And if I can keep my glucose, my hemoglobin A1C less than 5.4, my insulin less than 6, then I'm going to have better longevity. But so that's one thing. But they also improve lipid metabolism, helping to drive up the good lipids and drive down the bad lipids. They also, like metformin, increase AMPK pathway. So that's a large longevity pathway. So they have similar effects to metformin in that realm without the downsides of causing muscle loss because they don't block mTOR. They upregulate AMPK without blocking that ability to form muscle. Mm-hmm. They're really anti-inflammatory as well. So a lot of studies have come out now looking at them, for instance, in osteoarthritis because they reduce inflammatory markers. The cardiovascular benefits. One of the doctors in my practice, Dr. Hussein, is a cardiologist by trade, and he uses these a lot for cardioprotection. Mm-hmm. They can reduce atherosclerotic progression. So if I have patients who already have some plaque, I can stop the progression of that. In patients who don't have great cardiac function, you're going to improve their vascular output. They control blood pressure. And I think some of the biggest research now is in neurodegenerative diseases. So these drugs are in phase 4 trials for neurodegenerative diseases. I had a mom who died of dementia. The last place I want to go.
Same. Yeah.
So I will microdose these drugs. And for me, I'm pretty thin. So I have to keep it a pretty low dose to make me not, otherwise I don't want to eat and I lose weight. So I use it at a very low dose. And so I use a very low dose of these for its neuroprotection, for its cardio protection, to help me preserve lean mass, improve my muscle quality. So I think that this is a drug that, so we started in kind of our cellular medicine world using GLP-1 agonists long before they became famous in the Ozempic world and the weight loss world. And we used them primarily for these other benefits because we really saw them as a little bit better than metformin because of their not negative effects on muscle. So I think the GLP-1 agonists have to come in there at a low dose, guys. And a low dose, they end up being a lot less expensive too, right?
Right. Well, there's that as well.
Right. So a small dose weekly, and you're talking about maybe a quarter of the dose that you would need for weight loss, or in some patients, even an eighth of the dose. You don't need a lot of these drugs. I think they will get approval probably in about 3 years for treating cognitive decline. They're close. When they're in phase 4 trials, so about another 3 years, they will get approval for dementias. So, if you can start using them now, and again, sometimes your insurance isn't going to pay for those because you're not fat.
Right.
So you get them compounded, and use a small dose of them.
And that's really all you have to do. And anecdotally, it's really interesting to hear you talk about metformin and the mTOR and then bridging that into the GLPs. Just as you were talking anecdotally, I'm thinking back to when I was competing. So I used to compete, and that's when I was misdiagnosed 6 different times for my thyroid problem when I was gaining weight during a show prep.
Right. I remember you telling that story. Yeah.
Oh yeah. And it was bad. But at the same time, I was also diagnosed with PCOS. What was I put on? Metformin. When I look at my body, and I went off of it, honestly, I went off of it probably like 5 or 6 years ago. Not even because of the mTOR, just because it kind of went away. I had better metabolic control. I was using berberine instead, so I was fine. But what I've noticed, and now I do use microdosing GLP, just the same thing as you said. I had mom passed from Alzheimer's. Her grandfather had it. I have the APOE4 gene. I know I'm set up for it. the inflammation, all of that. So now I'm microdosing a GLP, and my body comp is better now at the age of 50. So muscle versus fat, even the muscle pumps that I get in the gym, the shoulders that I was going for when I was competing, and I'm like, I can't get that cap shoulder with the striations. Now I have it. I mean, number one, I'm not cardioing myself to death, but
Yeah.
number two, I'm not taking metformin anymore. Now I'm
Yeah.
thinking, oh my gosh, I think that was a
Yeah. The effects
component.
it had. Right. Right.
Yeah.
And now and then you hear all these people saying, and even hear some of these pretty prominent doctors on podcasts telling people the GLP-1 agonists make you lose muscle, and they do not. And so that you actually can use them to help build muscle because they actually pump glucose into the muscle. So you're right, they can be utilized to help muscle building, again, used at a low enough dose so that you don't get the side effects. You're talking about a weekly injection to help your brain and everything else. I think honestly, these are drugs, and we've got three now. You've got the semaglutide, and then the next generation, which is a double agonist of GIP and GLP. That's tirzepatide. Now we have retatrutide, which is a triple agonist, which may even be the best of the bunch. A little harder to get and a little pricier, but it may be the best of the bunch. But even just semaglutide, the simplest of the bunch, the GLP-1 by itself, used at a low dose is so valuable. And I wish we could stop the press from bastardizing these drugs so much, because I think that they're doing a lot of harm to the public good, because I think these drugs can be so useful. And I love that you're out there teaching people this, because it's so important.
Yeah, same. I mean, we were both spreading the word because I agree with you. I think it has such tremendous potential across the board for so many conditions, including metabolic conditions.
Right.
Yeah.
Yeah. And again, metformin for the right person may not be a bad drug, right? Let's see what else. I mean, there's rapamycin, right? Rapamycin probably has the most press of all of the longevity drugs,
Yeah.
because it has probably the most animal data behind actually improving longevity. Because in at least rats, dogs, monkeys, it does significantly improve lifespan.
Is there a
Healthspan, don't
downside
know,
to
but
it?
significantly lifespan. And
Downside
why
to
is that? Well,
rapamycin. Yeah.
because think about mTOR. mTOR is mammalian target of rapamycin. Rapamycin blocks mTOR completely, much better than metformin. It is a complete block, which if you took it continuously, you would lose all, which is why we treat cancer with it, right? So rapamycin was a cancer drug, still is. So it's, it was utilized as a chemotherapeutic agent for cancer, or after you had organ transplants to keep your body from rejecting the organ. Because in those cases, we've got to just block cellular health, cellular growth. The downside of cancer is you got to sort of keep people alive just by killing off everything that's good for them.
Right.
So, but that was used at a regular dose every day. But what if I block mTOR once a week, or for a few weeks every few months? So if I just turn it off completely. So now I've sort of, in one sense, if you think about AMPK as the long run and mTOR as, I always think about AMPK as our endurance runner, and mTOR as our bodybuilder, right? Okay. And so, the bodybuilder can go short term and hard. The endurance runner can go for a long time, but the endurance runner is really skinny and, doesn't have tons of muscle. So in our life, what we'd like to do is have that endurance, right? But get some muscle on and then block it, and then muscle on and block it. So the best way to take rapamycin, and what most of the data supports, is cycling it. And the problem is, what is the right cycle? Most people now are doing about a 6 milligram once a week dosing. Is that the right dose? Don't know. Mikhail Blagoslani, who is out of Russia, who studied the most, he just recently passed away of cancer, but he had the most research on metformin, thinks that's probably underdosed. But most of us are a little bit side of conservative treatment. So I think that when you look at the research on mTOR and the mechanism, it probably is the most likely to be truly a longevity drug, because it's addressing the really number one factor. But it has to be cycled. It can have side effects. Like if you take too much, it will suppress your immune system. So people will get cold sores, things like that. Some people will see lipid elevation. So you've got to find the right dose for the right person of that drug. It's, to me, I think it might be the most powerful of the lifespan extending drugs. I don't know about health span extending, but some of the data does support that. For instance, in rats, when they started it early, they maintained ovarian function much longer. So the rats were able to reproduce much longer. So maybe, all all of the women now who are delaying childbirth, right? People aren't having kids in their 20s, they're having kids in their 40s, right? If we want to maintain ovarian function, starting rapamycin at a younger age may be beneficial. So I think that this is a drug to use for, like I take it. I think most longevity doctors do take it. But I think it should be done with guidance of somebody, right? So you kind of know finding the dosing that helps things. I will tell you, like in your thyroid world,
Mm-hmm.
it can actually really help thyroid function, especially in some of the autoimmune thyroid people. So I've seen improvement there
Oh, that's
as well.
interesting. Okay, that's interesting as well. And then, of course, in that thyroid function, in that thyroid world, I'd like to transition into low dose naltrexone. I've heard you talk about that. I've talked about it as well.
Yeah.
I love it for reducing antibodies and reducing inflammation, but I
Right.
want to get your take. What I have seen in some people is, I mean, number one, it can affect their sleep. Number two, it can produce this flat affect, almost like they're taking an antidepressant, but they're not. And then number three, I've also seen increases in cortisol and weight gain when on LDN. So for those people, I tend to just use black cumin seed oil. But based on what I just said, what are your, I want you to unpack LDN, and have you seen those side effects like I've seen?
So low-dose naltrexone is a really interesting drug, right? It works in sort of two ways. It sits in the opioid receptor. So there's actually two isomers, and they kind of both have different effects. So when you look at the LDN molecule, it's actually kind of two different molecules put together, and they both have different effects. And one works by temporarily blocking opioid receptors. So the reason the drug got discovered was one of the major HIV researchers out of New York was taking his HIV patients who had chronic, usually were drug addicts, right? He was trying to wean them off their drug addiction using naltrexone. So naltrexone at a high dose is used to help wean off drug addiction, right?
Mm-hmm.
Or to block the ability of the drugs to make you feel good. So that's at a 50 milligram kind of dose. And then as they got better, he would start weaning them off the naltrexone. And all of a sudden he found when they got to a really low dose, like a few milligrams, 4 milligrams, their HIV numbers got better. They felt better. Their immune systems were better. They felt healthier. So that's how the drug got discovered. So basically, what happens is when you temporarily block the opioid receptors, you get this kind of rebound effect of endorphins and things. I think that's where some of your mood changes come from. Is in some people who have more delicate balance of their serotonin systems, that may be a negative effect. Is this kind of rebound of the endorphins if that's going on for a long time. I think lots of those people are probably people who have gut problems, and you have to go after the gut metabolism, that they're not metabolizing tryptophan well into serotonin. If you fix that, the low dose naltrexone doesn't have that effect. So I think you guys have to look back at the gut when you're seeing those people who are having weird responses like that to the LDN. But so by doing that, it's increasing these endorphins, but that temporarily also helps our immune system. So when we do that temporarily block of the opioid receptors, our immune system spikes. And so we get this big immune response to stabilize, not accelerate the immune response, but stabilize it, which is why it's so useful in autoimmunity, right? So now by this effect on the opioid receptors, you're helping with pain at a low dose. It helps the pain a little bit. You're helping with autoimmune function because I'm stabilizing the immune system. I'm lowering things like interleukin-6 and tumor necrosis factor alpha. So I'm helping the chronic inflammatory state. And in some people, improving mood. In other people, I think you see that effect, and I think that depends on what their gut metabolism is going on in that. So I do like low dose naltrexone. You're right. I use it in all my people with high thyroid antibodies. Some people work, some people doesn't. Is it a longevity drug? Some people would advocate yes, because one of the big issues of longevity is a decline in immune function. So all of us will get a decrease in our natural killer cell activity. We'll get a decrease in our ability to build antibodies, to make antibodies. That's why old people die of viruses and young people don't, right? We can't mount a good antibody response. So one of the biggest things that affects our health span is a decline in our immune system. So if I'm helping support my immune function with LDN, will I secondarily help longevity? Yes. So even though it has not been touted as a longevity drug, yes, I think that it can really be helpful there. Now, I do think there's better ways of modulating the immune system for longevity. So I will use this drug more in my like cancer patients, autoimmune patients, and not so much as a longevity drug, partly because it is, as you said, it can be a difficult drug sometimes for people, right?
Yeah.
You got to titrate up slowly. They get nightmares. Some people have trouble sleeping. So when I'm looking at a longevity drug, I'm going to try and find something that I don't have to deal with those kind of effects as much. But I do think, and like I use it the same way you do. My Hashimoto's patients, LDN, gluten-free diet, low dose naltrexone, all super important to help lower thyroid antibodies. So I think that immune system modulation effect is real. That's why it's so helpful in cancer. It ups natural killer cell activity, which we know declines as age. In fact, if you want to spend a lot of money, you can go to another country and get natural killer cell infusions. Natural killer cell decline is one of the big reasons we develop cancer as we age. So if we can keep that number up, so I think it's preventative effects for those kind of things like cancer and immune system decline, probably great. I don't know if there's probably better ways of doing that, and particularly with things like peptides.
Right. Absolutely. I agree with you there. Okay, a couple other ones that I want to get in before we move into peptides. I've heard you talk about Emlexinox. Am I saying that right?
Uh-huh.
And some reducing inflammation as well. So kind of on this whole LDN, GLP reduction of
Yeah.
inflammation helps the whole body because inflammation spurs every single disease. And it actually has a little bit of a weight management support aspect to
Actually,
it as
yeah,
well.
that's probably where it will come to market as a drug, is for weight. Interesting enough, because it's such a huge market. Like nobody really cares about everything else, but everybody cares about being thin. So Emlexinox is a cool drug. It actually was a drug utilized here called Apsol. So and it got approved for treating aphthous ulcers, so cold sores. And how painful and horrible cold sores can be, like if you get them on your gum or tongue or things like that. So it was great. It was a little paste that you could put on that. The problem was that the drug company basically stopped making it because people didn't really like it. It burnt a little bit when they put it on, so nobody really bought into it very well, even though it worked well to treat the cold sore. So they just didn't have enough in the market, and they've actually just shelved the drug, at least here in the US. Now, I will tell you, in Asia, is still a widely used drug, primarily for treating allergies and immune system dysfunctions. So it's a great drug because of the way it works on the immune system for treating allergic responses. So it's a great drug for allergies, for asthma, things like that. Widely used drug in Asia for that. But here in the US, here in the US, it basically got shelved. So the drug company wasn't making enough money, so they didn't discontinue the drug. Like if you look at the data, and you're like, this was pulled from the market. It was pulled from the market because the drug company wasn't making money. It was never felt to be unsafe or something like that, right? It was just not making money,
Right.
which is the big thing you want when you're a drug company.
Right.
So basically, we started looking at Emlexinox's other effects, which are huge. So Emlexinox actually is really good at treating inflammation. And what they found is, because of some of its very distinct effects on some inflammatory markers that also seem to be linked to fat cell gaining fats, because gaining fat's actually an inflammatory disease, right? Fat cells are inflammatory. We gain fat. And so some of those people who still are metabolically sound, like you look at them and they're like, they're maybe eating well, and yet they, so that you got them on the right diet, you've got their thyroid optimized, their insulin levels are good, and they're still not losing weight. A lot of times there's a big inflammatory compound to that. And it's because these fat cells produce so many inflammatory compounds themselves that basically they compound more fat. I'm in an inflamed state. My body's stressed. It says I need more fat. So people can't lose weight. So what they found is with Emlexinox, it worked very specifically on these inflammatory compounds produced by fat cells. And when people were put on Emlexinox, they started losing weight. And in fact, even fed the same diet, everything else the same, they lost weight. And in fact, for me, I don't use this drug that much for weight loss. I do in some of my patients who do have a lot of inflammatory compounds to their fat loss. But the biggest side effect to me of this drug is weight loss. So I love this drug for other things, which we'll talk about. But the biggest side effect is that people over time, it's not this like fast drop off, but you'll just see they just like, oh God, I just keep getting a little thinner. So over a year now, they've lost 50 pounds, right? So Lexinox, again, approved drug is Apsol. So basically, because it's available as an approved drug, I can get it compounded. So I can basically have a pharmacist get the chemical, which is available, and get it compounded as an oral medication. And as an oral medication that works on all these inflammatory components, seems to be, there's a great article on, is Lexinox a red light cure for everything? Because of all the factors it works on are so connected with fat, being metabolically unsound, being fat, having cancer, all these bad diseases. I use it primarily for immune diseases. So this is a place where somebody's not tolerating LDN, for instance, or they have, I would say, more of my inflammatory, like rheumatoid arthritis people who have a little bit more serious problems like that with immune function. This is a really good drug. I have an autoimmune disease. This drug is hugely beneficial to me, but I have to modulate it because I get too skinny. So it's a little hard. I keeping weight on is hard. So I have to kind of dose it a little bit lower than I might like for what I feel best at. Okay. It's a really nice drug, and doctors don't know about it. Its side effect profile is almost nothing, even at a very high dose, except weight loss. So, right. So Lexinox again, and if you guys look it up and you see, my gosh, this drug got pulled. You have to always be careful when you see these drugs pulled from market, because why was it pulled from market? Not because of anything bad, and that happens a lot. I have a lot of drugs like that. I mentioned patients, and they look them up, and they're like, "Well, this got pulled from the market in 1995," and I'm like, "Yeah, because nobody made any money." Right. So this drug I will tell you, it is in I think phase 3 trials now as a weight loss drug. You'll see it come to market probably in a couple of years as a weight loss drug. Which, hopefully then we have access to it for a lot of other things too, because it is really, I use this drug a lot. It may be one of my top drugs to go to at my autoimmune patients and my cancer patients as well. Yeah. So it's a really good one to keep in mind.
Okay, so for a person like me, maybe we haven't touched on everything yet, so you might stack on a couple more. So, person like myself, that family history of dementia, Alzheimer's, also family history of cancer, and I have 8 complex atypical hyperplasia cells in my uterus, which I'm not taking my uterus out. I'm trying to just, beat this and not have it turn into cancer, right? So what would you stack for me if you were like, this is about longevity, preventing cancer and protecting my brain?
I mean, you're already doing a low dose GLP, and that would be top on my list, right? I would definitely, in somebody who has a cancer history and has hyperplasia of cells already, I would hit with rapamycin, right? You've got to, so if weekly I'm doing this thing that's blocking anything from those hyperplastic cells are growing too fast, right? They're in an mTOR driven state. So if I shut them down, even for a few days or a day a week, I get this die off, right? So the cells grow, I kill them. The cells grow, I kill them. So for you, rapamycin is a really good drug. I think that, using a 6 milligram once a week kind of dose would be a really good thing for you. I would say Lexinox is also a nice choice because of its cancer prevention properties. My concern with you might be weight loss. Right. If you could maintain your weight on it, especially with a low dose GLP, I think maybe they compound each other a little bit, right? So, yeah. So would you get weight loss on it? Possibly. So, but I think if you go with just a GLP-1 and you go with rapamycin, those two together, I mean, the GLP-1s also have great anti-cancer benefits too. And even the thyroid cancer guys, honestly, the thyroid cancer risk of GLP-1s is way overblown. At this point, really, they tried to get that black box warning off of these drugs. Yeah. Because we don't have the same GLP receptors in our thyroid as mice do. So even though these did cause thyroid cancer in mice, there's no evidence that it does the same thing in humans. So I think I saw Mark Hyman do a post, or his people do a post recently. I don't know if you saw it on, we're seeing this huge rise in thyroid cancer now that people have been taking these GLP-1s. The reason is because now everybody's getting screened for thyroid, because anybody who's put on a GLP-1, their doctor is required to test thyroid. So now they're finding abnormalities that have nothing to do with the drug, right? It's just now that most of these doctors didn't look at these thyroid functions, all these thyroid functions, and now they are, because it's kind of a requirement to do that if you're going to have somebody on that GLP-1 long term. So we're finding a lot more cancers. There's been no evidence of cancer induction of these drugs, and if you look at the mechanism, they shouldn't cause cancer in humans. So the GLP-1s, if anything, are much more preventative to cancer than causative to cancer. So I probably would go with those. Those for you. If you want a fun drug to try for you, Amy, with your workout stuff, my other fun repurposed drug that I use is telmisartan.
Oh yeah,
Telmisartan is a blood pressure medication. Yeah, so it's basically what's called angiotensin receptor blocker, and another banned WADA drug, right? So if you're doing any tested athletes, you can't use this drug. But the angiotensin receptor blockers, and particularly telmisartan, so there's other angiotensin receptor blockers, but telmisartan appears to have the strongest benefits here, has what we call activation of something called PPAR gamma. When you activate PPAR gamma, you initiate endurance. You initiate, where you can just, power. So PPAR gamma activation, it initiates more power. So you get this marked improvements in like your endurance capacity and your performance capacity. So I particularly, because I don't like doing endurance. So if I'm doing like a zone 2 longer training, day, I will do telmisartan ahead of that because it will give me the endurance to get through that, because I don't like it. But even you'll find if you're doing a hard workout, like a hard lifting workout, you can get a little more muscle pump with activating these. The telmisartan also has some really nice data on preventing cognitive decline as well. And there's like a fair number of pathways and influences. So I think it's actually a really interesting longevity drug. And essentially I fed all these longevity drugs into AI just for fun one day. I just fed every longevity drug I could think of. And I said, okay, based on cost, side effects, scientific data, which of these drugs, if I could only take one, would you take? And they came up with telmisartan. So, interesting. And it's inexpensive. You're not going to take doses that lower blood pressure. You're just going to take a low dose of it, like 20 milligrams. And we have all these other benefits. So it's one you can kind of use, you can sort of play with, like when you're doing a more endurance workout, you're going to go out for a hike, you're going to go to altitude. It's a great thing to take for altitude training. Or if you're going to go skiing in where I live, Colorado, then you might want to do a little telmisartan ahead of time. So it's also a nice drug that you would have fun playing with your kind of exercise regimen that you do, just taking it, periodically, even if not every day, but like I do it more on my heavier workout days or my endurance days.
Now, do you stack that with the Cialis microdose?
Yeah, I do. So I take Tadalafil every day. 5 milligrams of Tadalafil, just because I do think that, I think my mom died more of a vascular dementia, not probably Alzheimer's dementia, but vascular dementia. So that's these, all these little blood vessels just start to get damaged. And, so that's where Tadalafil, I think, is really going to be helpful. Also, if any of you guys have like I have pretty bad Raynaud's. Like if I get in the cold, my hands get really numb and white. And so it really improves that vascular flow to my fingers for the cold. So, so it's a really nice drug for me.
Oh yeah. Oh yeah. Oh, I love this. This is such gold. This is amazing. Okay. Are there any repurposed drugs that I missed that you want to talk about before moving on to peptides?
No, let's make sure we hit a few of the peptides.
Okay.
They're one of my passions, because peptides are so powerful. And I think the repurposed drugs are nice, right? Because, we don't have as much scientific data on peptides, at least in human models, right? The repurposed drugs are nice because we know their safety. We know we know that they've been used lots of times for 30 years in humans. So whereas the peptides, we have tons of animal data, and I love peptides. I think they're very safe, but and I think sometimes people are like, oh, I'm going to want a peptide more than a repurposed drug. I honestly think if you look at data, there's more safety background behind the repurposed drugs. But I love peptides, particularly a few that I think are probably essential to maintaining health and longevity.
Yes. Dive into those. Yeah.
So I don't know. I mean, would your listeners, so just to kind of go through what is a peptide, right? I don't know, if you guys have talked about that before.
We've talked about it, and I just kind of skimmed the surface. Well, I had Dylan Gemelli on, and we dove into peptides. He absolutely loves you, speaks your praises. So we touched on like the BPCs, the GHKCU,
right,
but really not as it specifically relates to perimenopause, menopause, thyroid, because that's the audience. So if there are specific ones. Like, for example, I know that if I get a surgery, I'm going to take BBC, TB500, and GHKCU stacked for better healing. But what I don't know is, should I be taking BPC all the time for another benefit. I'm not sure. I know it speeds healing and I know it helps with injury, but there might be things that I'm missing in the big well-known peptide list that we could be using it for other things as well.
Yeah. So I think yes. So first of all, let's just, for your listeners, let's reemphasize what is a peptide. So peptides are short chains of amino acids. They're basically mini proteins. Whereas a protein's 50 amino acids or more, a peptide is less than 50 amino acids. And what makes them kind of so valuable for like the world we're talking about, for thyroid function and hormone function, everything else, is that they're these really important messengers in the body. So whereas a hormone may have a pretty wide range of activities, a peptide has a very specific cellular response attached to it. So they're a lot more precise sometimes than medications could ever be, or even hormones could ever be. They're very precise in how they work in these existing biologic pathways. So the other thing is that a lot of the peptides we use, not all, but a lot, just like your bioidentical hormones, are made by our body. So yes, we synthesize them, but they are bioidentical to what our body makes. So when you talk about things like BPC and thymosin beta 4, which is the real name of thymosin 500, these are peptides that our body makes naturally, but decline as we age. So when you talk about, okay, you're 50 and your hormones are declining, and you can either accept that your hormones are declining or you can replace them. Well, the same thing is true about peptides, right? That one of the reasons I'm aging is because some of these peptides that I had tons of when I was young, these are endogenously made. Like BPC is made by your gut. So it's a gastric peptide made by your gut in response to kind of healing. But your body's always healing. It's not just after you have a surgery or you have an injury. It's always having to repair and heal. So if I could keep my BPC levels up at the same levels they were when I was young, just like my estrogen and testosterone and progesterone, will I age better? In all likelihood, yes. And I think the two most important in that group are the thymic peptides, and particularly the one thymic peptide that is important for our immune system. So one of the things we've really equated to aging, and nobody will deny this, is the loss of our thymus gland. So when we're born, we have this giant gland in our chest. Like you take an X-ray of a baby's chest, they've got this mass in their chest. That's the thymus gland. About puberty, it starts to go away. So it just starts to atrophy. And by the time I'm in my 60s, by the time you're as old as me, it is a little fatty nub not doing anything. So why is the thymus so important? Because it makes thymic peptides, one of which is thymosin alpha 1. Thymosin alpha 1 is the most important immune peptide that we have in our body. So if we're exposed to something, if we get a vaccine, if we have cancer, the thymic peptides are there to tell the immune system what to do. If I no longer have them, my immune system goes haywire much more easily, right? Autoimmune disease or natural killer cell activity going down. My immune cells no longer have, it's kind of like having a bunch of soldiers that you've brought in, but nobody's trained them. You just gave them a gun and said, go do something, right? So that's what happens to our immune system. We no longer have the master regulator of our immune system, which is the thymopeptide, thymus alpha 1. In other countries, thymosin alpha 1 is a drug. It's called Zadaxin, not available here, unfortunately. But thymosin alpha 1 is a key regulator of immune function. So when you look at its advantages for immune modulation, we talked about, okay, well, if I'm going to use something for low dose rather than low dose naltrexone, what's a much better immune modulator? Do it the way my body does. So what the thymosin alpha 1 is going to do is it's going to improve T cell production and the maturation, the appropriate maturation of those T cells. It's going to increase my natural killer cell activity, think cancer. It's got significant antiviral properties simply because my immune system is going to be able to recognize a virus, mount an appropriate antibody response, recognize the virus the next time I get exposed. So if you have cancer and you live in Asia, or India, you're going to be put on Zadaxin, right? Because they want your natural killer cell activity better. They want your immune function better, but not here. Here it's a peptide that you have to get. It's so more difficult to get than a lot of peptides. But if I could keep that up, so I think, and then the other thymic peptide is thymosin beta 4, which you talked about, known as in the kind of the regular world TB500, but as a real peptide, it's thymosin beta 4, which is also produced by our thymus gland, which you don't have anymore. And that's a really critical peptide for repair and regeneration. So that's why we use it for wounds or for surgeries or for injuries. But that process is going on all the time, right? It's why when you get old, it's like, you bent over to put your shoe on and something got hurt. It's because you don't have these things that are constantly repairing your tissue. So what I like to do for my patients is to look at those peptides that are naturally made, endogenous peptide, BPC, thymosin beta 4, thymosin alpha 1, the growth hormone secretagogues, and utilize them in a cycled basis because it gets tedious and pricey to use them ongoing, right?
Right.
So what you can do is cycle them. You do a 6-week, 12-week cycle, and then you go off them for a while, and then you do a 12-week cycle. That way, I'm keeping my body at a nice level state of these things that I had a whole lot of when I was 15, 16, but I don't have anymore. So I want people to sort of think about peptides a little bit more just as being utilized in these specific cases, like you would hormones. Like you're not just going to, start taking testosterone because I'm going to do a show, so I'm going to take testosterone for now. You're going to take testosterone ongoing because you're not making it anymore, right? Correct. Or you're not going to just take estrogen because you started losing your hair and then you took estrogen for a while, and then your hair came back, and so you stopped it. No, you're going to try and keep it at that same level as when you were young, because we know if we can keep the same levels of these things, hormones, peptides, that I will not age the same as if I didn't have them. So what I do with most of my longevity clients is I will keep them on cycles of the, and because it gets overwhelming to do 18 injections, maybe I'll have them do, thymosin beta 4 for a little while, and then thymosin alpha 1 for a little while, and then BPC for a little while. So we can kind of cycle through these things. And then again, yes, using them more hardcore when you have something to treat. You just had surgery. You just had hurt your knee, right? Then you're going to use them more aggressively, but ongoing just as a preventative factor. Does that make sense?
Oh, yeah, absolutely. Absolutely. So that's good to know that you can actually use this. So I'll bring in thymosin alpha if I'm going to be traveling, or today my
Right.
husband woke up with a sore throat. So I'm jamming
Exactly.
myself with the thymosin
Yeah,
alpha to
exactly. And
boost my immune system.
that's a great thing to do. But cycle it. Go 6 weeks, maybe 4 times a year. Do a 6-week cycle.
Mm-hmm.
I mean,
Okay.
they're trying. One of the biggest things going on in regenerative medicine is trying to like recreate a thymus gland, right? Well, we can't do that yet. Eventually, you might be able to, but we can give the peptides it makes. So think about these just like, okay, my ovaries aren't making estrogen and progesterone anymore. My thymus isn't making thymosin alpha 1 and thymosin beta 4. So I'm going to give them back just like I give myself estrogen and progesterone, right?
Yes. Now, what do you think about the bioregulators? Something like a Pidolon, or I know that's a peptide too, but then we can
Right.
also find it as a
Bioregulator peptide, right?
Which one do you like
So,
better?
so I think peptides in general have more research behind them. I would say I was pretty skeptical of bioregulators. All the bioregulators come out of Russia. Dr.
Mhm.
Kavinson's lab. So Kavinson, who recently died, too.
Yeah.
He basically has all the research and it's patented research on the bioregulators. So it's a little bit hard because we don't really have the research here to support them. So I was pretty skeptical of them. So for your listeners who don't know what the bioregulators are, there's very short chains of peptides of amino acids. So 2, 3 amino acids. So tiny peptides. And as such, most peptides you can't take orally. There's a few you can. BPC can be taken orally. But in general, most peptides, if I take them orally, get broken down in my gut. So we have to do an injection of them. But if you have a very tiny amino acid sequence, 2, 3 amino acids, it doesn't get digested by the gut. It can then integrate into your genome to alter an epigenetic presentation. So you actually get your body to produce more of something, right? Reestablish circadian rhythm. And again, the data again is almost all out of Russia's data, but I do use them. And I do think that they have some benefits. Do I think they're as powerful as peptides? No. But I do think they have benefits, and I do utilize them. Like when I'm trying to get somebody's adrenal function better, I do think adrenal bioregulators can be super useful there, or thyroid bioregulators can be super useful there. I think that in general, pineolon, which is another bioregulator, can be also helpful for helping circadian rhythm, particularly for if you guys are doing travel and get jet lagged. I think that those can be utilized too. Although I like the compounded peptide version of like epitalon, done as an injection. I think you're going to get better benefits that as a course. But in general, I'm keeping an open mind to them. I don't think I have all the research I need yet to say these are the end all be all. But I think there may be some good to them. So I think that I'll stay open minded to them, and at this point I'm using them with my patients, and I am seeing some benefits.
I'm right there with you with the even with the thyrogen.
Yeah,
I've used it with patients, but I find it almost works better on the hyperthyroid patients to kind of bring them down and balance them out, as
interesting.
opposed to the hypo. Because with the
Right. So more
hypo,
kind
it's
of
like,
regulating that. Yeah.
yeah, you're asking a thyroid gland that may or may not be 10
Yeah.
years beaten up by the immune system to now
All of a
produce
sudden wake back
adequate.
up. Yeah. Yeah.
Yeah,
Probably not going to happen. Right.
right, right,
Yeah. I think
exactly.
the same thing's true with like, you're probably not going to get your hormones up by using but some of the bioregulators, like the ovary bioregulators. I don't think if you're, if you're older, that's going to happen either. I think you're going to have to replace some of these things because of the, the aging process. Uh,
Exactly. Yeah, I completely agree with that. So definitely peptides over bioregulators. Any peptides that we missed that you just like, what's your favorite one that you want to talk about before I move into hormones?
I think those BPC, thymosin beta 4, thymosin alpha 1,
Yeah, those are the big ones.
definitely my favorites. And then the growth hormone
Yeah.
secretagogues, CJC, ipamorelin, or tesamorelin, ipamorelin. You remember,
What do you like
I'm
for
not a big,
women? Because there's
uh,
so many of those. They're almost overwhelming even to me.
so for most women, did I disappear?
Yeah, there you are.
I'm
Okay.
back. So for most women, a lot of times I'll find tesamorelin, ipamorelin. So to understand growth hormone secretagogues, they're telling your pituitary to both make and release more growth hormone. Okay. So basically, if I just take growth hormone, the problem with just taking growth hormone is I get this big massive surge in growth hormone. And the problem with that is if you think about the old bodybuilders, and you'll still see this in the bodybuilding world, is that remember they had those kind of like weird turly bellies, like,
Yes, yes, the turtle
very strange.
shell.
That was growth hormone, because what growth hormone causes is organomegaly. It makes your liver and your spleen big. So their bellies would be sticking out like this. And yeah, they would be cut like they have muscle. It's
Yeah.
because their organs grew. And unfortunately, that's irreversible when that happens. So you'll still see these old bodybuilders have that turtle belly from taking growth hormone. So growth hormone you have to be very careful with. And I see a lot of doctors still prescribing it. Secretagogues are much more balanced. They're going to cause your own levels to be more physiologic. And so we usually use as a combination what's called a growth hormone releasing hormone with a growth hormone releasing peptide. So like CJC and tesamorelin are both growth hormone releasing hormones. Ipamorelin is a growth hormone releasing peptide. So you use those in combination sometimes. Tesamorelin is great. It's very strong. Some women love it. I hate it because it really, for me, I get edema. I get every side effect of raising growth hormone too much. So for me, it doesn't work. So lots of women seem more sensitive to those stronger growth hormone secretagogues. Whereas, so CJC and ipamorelin, I think, tend to be the easiest go-tos because they're enough, but not too much. And usually use these as a 5 out of 7 day a week thing, primarily before bed because it helps deep sleep, things like that. There are some interesting oral growth hormone secretagogues coming out. We've always had something called MK677.
Okay.
And MK, you might remember from your bodybuilding world, was used a lot because it would actually stimulate appetite. I will use it for my bodybuilders who want to bulk, right? Because it makes them want to eat and they put on a lot of muscle. But most people don't want that desire to eat all the time. So MK has its downsides. It is a nice way of orally. It's what's called a Ghrelin agonist, but it's nice to not have to take an injection all the time. But there is some newer ones, something called Massimorelin, that is actually not so bad at the wanting to eat, but it may be a nice oral growth hormone secretagogue that kind of just got available to us. So there's some cool, nice oral ones that I'm keeping an eye on too, because, I don't know about you, but I just find sometimes these injections, I've been doing them for a long time. You get injection fatigue, right? It is just sometimes so hard.
It is so real. And especially with the growth hormone ones, to have to take it before bed.
Right before bed
I
on
get into
empty
this,
stomach. And
yeah, on
yeah, me too.
empty
I'm
stomach.
tired.
I'm
It's like
tired.
I'm tired. I'm like, the last thing I want to do is go pull my stuff out of the refrigerator, pull it up, and yeah, like I'll sit there and just go, nah, I'm not gonna do it today. It's like,
Same. Okay, that makes me feel better. I'm not a bad biohacker.
yeah, no, I know there are some people who are so great. I have patients who are so diligent and so great, and I don't know, maybe it's our lives. My end of my day, I'm like done. I'm like, okay,
Now
I
I
can get
saw
down my
this oral.
magnesium. That's about it.
Well, yeah, that's exactly anything oral that I can just swallow. That's fine. I can get that down before bed. But beyond that, now there was one. I have to find the picture, but I want to say Is it somatropin? It's an
Somatotropin.
oral.
Yes,
Yeah.
somatotropin is an oral you do under your tongue. It was actually one of the first kind of growth hormone secretagogues we ever had.
Okay.
Um,
Does it
it's
work?
basically just a couple of amino acids. It
Okay.
does work a little bit. So I actually keep it by my bed. And like if I didn't do my injection, I do like 6 sprays of it because it does something. Is it going to
Okay.
get your IGF levels up to really nice levels? Probably not, but it does something. So I do, and a lot of my patients who are just they're not going to take injections, they're not going to do this. I can stick a little thing of somatotropin at their bedside stand, right?
Yeah.
And do it secretropin. Yeah.
Yeah. So it's better than nothing. Exactly.
Yeah.
Okay. Now, I know we're running short on time, but before I let you go, I have to ask you about this one hormone. Now, the other hormones, I know you and I are on the same page. We love hormones. We love replacing hormones, male and female. But, there's this one that it's going to kind of actually tie back to when you were talking about AIDS patients and how some drugs that we use now for other purposes really came out of the AIDS epidemic that we had in the 80s, 90s. And this one it started in the bodybuilding world as the girly steroid Anavar. It's actually oxandrolone. Got its start as a preventative for the sarcopenia that occurs with AIDS and HIV. But now we're seeing it come into mainstream and actually be compounded in compounding pharmacies.
Mhm.
And I use it. I cycle on and off of it along with my testosterone. And I really feel like it helps me maintain my muscle mass and actually give me that little bit more body comp, a little bit better pump. So what's your take on oxandrolone? Are you using it in practice as well?
So if you look at that, so these are anabolic steroids, right? So the two that are probably most popular are oxandrolone and nandrolone.
Hmm.
Um, and and oxandrolone is oral, nandrolone is an injection. So the downside of oxandrolone is a little tough on the liver, right? So
Hmm.
it's a little liver toxic, so you have to be a little more careful with it. But it is a nice anabolic steroid in terms of what you're describing. So for your listeners, what is an anabolic steroid? Why is that different from testosterone? When you look at testosterone, it's about 1-to-1 androgenic anabolic, right? So think about androgenic as everything you think about a guy, and then anabolic as muscle building, bone building, growth. So if you have something that's 1-to-1, so if I wanted to push testosterone up to really put on muscle, I'm going to get a lot of androgenic side effects from it, right?
Hmm.
Because if I pushed it up 15 times, for instance, now I'm going to have hair loss and acne and aggression and all these bad things.
Yes.
So if I can use a drug that's more anabolic and less androgenic, then I can build muscle without getting those androgenic side effects. So that's what oxandrolone and nandrolone both are, is they're much more anabolic than androgenic. So usually you want to keep on testosterone when you're on these because you still want some androgenic effects, especially guys, right? They still want those androgenic effects. But now I want to boost up the muscle building capacity. I want to boost up the anabolic effects. I use these, and I end up using nandrolone a little bit more for one reason. It's because it has more medical literature on it. I love oxandrolone. I think
Okay.
it can be really great, especially for women, especially for trying to build muscle. But because nandrolone has more clinical research behind it, in my clinical practice, I oftentimes use it just because of that, because I can defend it a little bit better. So because when nandrolone first came out, it was actually for treating fractures and bone density. So it's and then it got into the bodybuilding world, and no doctors would prescribe it anymore. It became sort of an anabolic steroid that nobody should use. So it fell out of practice. It's actually a great drug for your women with osteoporosis, for instance. You cycle them on and off of it because you don't want them to get too anabolic, but you've got to build bone, and building muscle, building bone are so critical for longevity. So especially my more frail women, it can be a great drug for them. So you can basically, and oxandrolone as well. So both. So you can build muscle, you can build bone without getting the hair loss, the acne, all those other side effects. So think about this: 15 times the anabolic to androgenic effects, and you cycle them on and off, right? You don't do them continuously, and for both men and women. Nandrolone also has a lot of data in rheumatoid arthritis and in healing from surgery. So we use it
Oh,
on all of our patients who are recovering from surgery, like joint replacements. There's a great data on it after rotator cuff repairs or after joint replacements, that the healing was much more rapid with those people.
oh,
So,
that's interesting.
so we use it very often post-operatively in people.
Hmm.
And again, if you use it for like 12 week cycles, you've got to watch it, guys, because it is not testosterone. It's not as strong as testosterone. So they'll start getting signs of decreased testosterone if you have them on androgen without any testosterone backup. So, and women will get a little bit of that too. Sometimes the women need some of the androgenic effects, right? Sometimes the nandrolen's enough. So a lot of times you can just cycle oxandrolone or nandrolone. And again, they're very similar.
Hmm.
Again, I probably like oxandrolone a little bit because it's easier to use. It's not an injection. It's oral. But in my world, just because I'm working within more of a clinical practice, I tend to use ones that have more of a clinical background. But I think for like your case, oxandrolone is a great medication, right?
Well, and what are your thoughts on, do you use it with those women who have a tendency to push down that 5-alpha reductase pathway? I mean, you give them
Right.
5 milligrams of testosterone and they're just they're growing a beard and they're just breaking
Right.
out everywhere.
So you're gonna avoid a lot of that by using like oxandrolone instead or nandrolone
Yeah.
instead, right? Because you're not going to get those androgenic effects. So right. So you could cycle these instead, right? In men, you're going to lose erection quality if you don't have them on testosterone. In
Right.
women, not so much. So if they're really androgenic anyway, like your PCOS people or something like this, it's a way to get some of the anabolic effects without. Oh, by
Yeah.
the way, back into your PCOS, that's where the GLP-1s are equally as good as metformin, right? As your
Oh, well, better now. I mean,
Yeah, better now,
if we
right?
have a PCOS
Yeah.
patient,
So
let's
yeah,
do
so I'm
that.
glad you
Yeah.
brought up the anabolics because I preach anabolics a lot. I lecture at like Mr. Olympiad. We
Yes.
have this Olympia University, and and you always get as a physician, you get a lot of bad talk about using anabolics, and they can be so helpful
Yeah.
for healing and recovery. Honestly, so helpful. And I will say a lot of my joint pain patients feel so much better on the nandrolone because it has some great data, rheumatoid arthritis or arthritis in general, and it's hard to get them off. It's hard to get them to cycle off of it.
Now, is that a once a week? What are you dosing the nandrolone
Yeah,
at?
nandrolen's usually once a week.
Oh, that's easy then. And
Yeah.
again, like just a once a week injectable is easy for
Yeah,
people
it's
to
it's
do.
very viscous, so it's a little pain in the ass to draw up, right? Which
Yeah,
is why the orals. It's just if you're cycling oxandrolone a lot, you've just got to follow liver functions a little more closely. They will sometimes elevate a little bit, right?
exactly.
As long as you're
Exactly.
cycling it, that usually is not an issue. They go back down after you cycle off of it.
And then for men, for them to get the effect, I would think the nandrolone would be better because you have to
Nandrolone is a
use
little
such
more
a higher
powerful, yeah, than
dose.
the
Yeah.
oxandrolone. Yeah, yeah.
Yeah. And then that's really
Nandrolone has
unconventional.
more anabolic properties than oxandrolone.
Yeah. Okay. Beautiful.
Oxandrolone seems to be women do like oxandrolone,
Yeah. It's easy. It's just, yeah. Take a little pill every day. That's so much
right?
easier than an injection. Even with a little
Right.
insulin needle, you get injection fatigue. You
Yeah,
just
I
do.
mean, I talk about the anabolics a lot, and I feel like I'm one of the only physicians out there. So I'm glad you bring it up,
Oh, I love
because
it.
it's like it's sort of like in our world, even that sort of getting into the anabolic world. And I'm not talking about the bodybuilders. I'm talking about women who are frail, and elderly people who can't put on bone and muscle. These are great drugs.
Yes, absolutely. Well, I always joke too. I mean, my roots are in the bodybuilding world. I was in that world for so long, but I always joke that bodybuilders really are the OGs of
Oh my
biohacking
God.
because
So when I first got into this field, like 30 years ago now, honestly, I was like, that's where I was learning stuff because they knew a lot more than the medical doctors, right? That
yeah,
precision, you talk about precision and figuring things out to get that to do what they do at this precision level is not easy. And you have to be very knowledgeable.
right. SARMs, peptides, all of that kind of
Right.
started there. And
Exactly.
now we have like the Ben
Right, right,
Greenfields and
right,
Dave
right.
Asprey's of the talking about it. Like we did it first. We did it first. So, Dr. Yurth, I love your brain. Oh my gosh, I could seriously talk to you for hours. I'm bummed that I have to let you go because I know we both have things, but this has just been amazing. Absolutely amazing. I'm going to go back and listen to it and take notes because I couldn't take notes. I was talking to you. So I'm going back and listening to it and taking notes. You practice in Boulder. So can you tell people if they're looking to work with you, just looking to find you and get
Sure.
more of your brain, get more of your information, where can they find you?
Yeah, and we have two other great doctors with me, Dr. Fate and Dr. Hussein, and three great PAs. But we're in Boulder, but we're licensed through almost all states, almost all 50 states. So we see patients internationally. So we have a big virtual practice as well. So you just go to boulderlongevity.institute.com or boulderlongevity.com, and you could sign up there and get information. And Jessica can call and talk to you through what kind of a program would be. We have, you know, just orthopedic plans, because my background's orthopedics,
Mhm.
as well. We do a lot of regenerative orthopedics. We use a lot of these things along with our regenerative orthopedics. So we have all sorts of sort of directions people can go. So look on that site, it has a lot of interesting stuff. If you want to learn like the stuff that you teach all the time, Amy, is, we have an academy called BLI.academy. So if you go there, BLI.academy, it's our human optimization academy. There's actually courses on how to read your own labs, how to understand peptides, how to understand hormones. So you can learn this stuff yourself. So your doctor won't know it and you can help teach them, I hope.
Right.
Or find a different doctor.
Guide them
So go to
along.
BLI.academy if you want to learn more, sign up for the academy. Follow me at Dr. Yurth. We do these great monthly Q&As. People ask amazing questions. They're really smart people out there who ask amazing questions. So if you guys really want to learn that stuff, join the academy, get the Q&As, follow me at Dr. Yurth, and on Facebook and Instagram, and I hope to see you guys, because I love people like Dr. Amy and what you're out there doing and preaching. And if we can just keep spreading this, like each one of you now teaches more people and teaches more people, then maybe we actually can change this kind of messed up medical world.
I agree. We're pushing towards that. I think we'll get there eventually.
Yeah, eventually. I
Yeah.
hope.
Yeah. In the meantime, thank you for you doing what you're doing as well and spreading the
Thank
word.
you.
I greatly appreciate your time today.
Appreciate you. Bye, Amy.
Bye bye.